Hello, and welcome to the DeSera Clinical Education Oncology podcast. I'm your host, Amber Williams. Today's episode features Dr. John Heymach from the MD Anderson Cancer Center in Houston, Texas, and Dr. Solange Peters from the University Hospital of Lausanne in Switzerland. They will discuss key data presented at the 2025 World Conference on Lung Cancer regarding frontline maintenance for extensive stage small cell lung cancer and targeted treatments for non-small cell lung cancer, and how they may change the treatment paradigm. This episode is part of a larger educational program titled CCO Independent Highlights of the 2025 World Conference on Lung Cancer. For more information on Dr. Heymach and Dr. Peters, along with a link to the larger educational program, please visit the show notes for this episode. Now, let's get started and hear what the experts have to say.
Hi, I'm John Heymach, Chairman of Thoracic and Head and Neck Medical Oncology at MD Anderson Cancer Center in Houston.
My name is Solange Peters, and I'm the Director of the Department of Oncology in Lausanne, in Switzerland. And I'm focusing my research and my clinical opportunities in thoracic malignancies research. And it's my pleasure today to discuss with you some of the data presented at the World Lung Conference this year, trying to understand together how it may change the landscape and our practice on a daily basis.
We've seen a lot of changes in the landscape for extensive stage small cell lung cancer, so maybe I can put them all into context. Small cell lung cancer usually presents as extensive stage disease or metastatic. And, for over 30 years, the standard of care was etoposide and platinum. That was established back in the mid-'80s. So really, progress was very slow. I think the first advance we had in decades was the addition of PD-L1 blockade. And there we had the IMforte study, as well as the Caspian study. That's with platinum and etoposide with either atezolizumab in the IMforte study or durvalumab in the Caspian study. The results were really pretty comparable between the two. There was an improvement of a couple months in overall survival. So that was a clear advance. The range of numbers was from roughly 10 months to 12 months and change as a ballpark. There we see a hazard ratio for survival in the 0.7s overall. So clearly a significant advance, but something that was on the order of months for most people and not years of addition. But this was really the first standard of care difference in decades, literally. Right now, we're starting to see additions built on top of this base regimen, if you will, of chemotherapy with PD-L1 blockade.
I've been running many trials trying to implement something more than the usual platinum etoposide, now with a checkpoint, durvalumab or atezolizumab, trying, for example, to add some different maintenance, immunotherapy maintenance, but all of the trials at the time being failed. What is quite interesting now is that we start to see data changing the paradigm, not only of second and late lines, but the paradigm of the maintenance after 4 to 6 cycles of platinum etoposide and a checkpoint. And one of these important, I would say, new data set really changing the practice today is the IMforte trial.
So Solange, you were involved in this IMforte randomized phase 3 study. What are your thoughts about it?
IMforte is placing at the end of 4 cycles of platinum, etoposide, and atezolizumab, lurbinectedin in addition to the maintenance atezolizumab. In that trial, of course, it was compared to atezolizumab monotherapy, trying to show if the PFS and the overall survival could be improved. This is a challenging trial because it's chemo after chemo, and we all know that there is some hematological toxicity at the end of platinum etoposide, thrombocytopenia, anemia, sometimes leukopenia, sometimes requiring G-CSF. So we knew it would not be easy, but we also knew how fast the patient progressed, very often some weeks only after the end of chemotherapy in that specific aggressive disease. So the trial met the endpoint of improving progression-free survival, but also overall survival. And in a very meaningful and statistically significant, of course, manner, with had a ratio of 0.54 for PFS and 0.73 for survival, which I can tell you in small cell lung cancer is absolutely amazing.
And I'll note there have been regimens that have been tested in this maintenance setting previously, but this was really the first one that showed a striking benefit.
At the World Lung Conference, we did revisit altogether how we can manage the toxicity. We know that sometimes we need GCSF, and some centers decided to give GCSF upfront for all patients not to have trouble, because in the first 3 months of treatment, you can observe thrombocytopenia, neutropenia, and febrile neutropenia, but in a very small number of patients, the febrile neutropenia. So we have to keep in mind that this chemotherapy has the usual paradigm of chemotherapy toxicity, but mainly concentrated in the first 3 months of treatment, way less observed later on. The overall rate of adverse event leading to study treatment discontinuation was, at the end, relatively and surprisingly low in both arms, meaning that by managing these hematotoxicities we know well as some nausea and GI toxicity, we are able to continue the treatment and get the benefit in terms of survival and progression-free survival. So although a higher incidence of adverse event by adding lurbinectidine, this is manageable, mainly observed in the first 3 months, mainly hematotoxicity, and not leading to discontinuation. So I think, like any new strategy, we need to get acquaintance to this additional toxicity. We need to inform the patient for no surprise to happen, and sometimes to consider some local management, depending also on the patient. For example, giving GCSF if you feel like it's useful after 1 cycle or at baseline of lurbinectidine. But I think it's a very reassuring abstract telling that with the art of oncology, this is manageable.
So on that basis, the IMforte regimen has now been approved in the US, and I think justifiably so. So I think this is, from my perspective, the first real advance building on top of the IMpower133 and Caspian studies we've seen now in several years. The second big advance, now this is one that has not yet been formally approved, but it really shows us that T-cell engagers like tarlatamab can be a game changer, and this is the DeLLphi-303 study. Here in the DeLLphi-303, this is not a randomized study versus standard of care, but this is taking tarlatamab and adding it as maintenance therapy. So the same setting as we saw for the IMforte study. And this is for people who've had 4 to 6 cycles of chemoimmunotherapy and not had disease progression. And then they received either tarlatamab and atezolizumab or tarlatamab with durvalumab. So in other words, building on top of either the IMpower133 or the Caspian regimen, which, those two regimens tend to yield very similar results. This isn't compared to standard of care of chemotherapy with immunotherapy alone. Really, the results were pretty striking. And I think the number that really got my attention, I think most other people's attention, was the median overall survival from this study. The median overall survival in the atezolizumab arm was 25 months. In the durvalumab arm, it's not yet evaluable, but we can see it's going to be a long number, presumably in excess of 2 years. The overall survival for the entire group, when you combine the two arms, is 25.3 months. Now, I will tell you that I was in the room as this was presented for the first time, and there was really sort of a gasp in the air. That's because for years, those of us who've been studying small cells, actually decades, we really have been stuck in that 10-month range, getting up to 12, perhaps with immunotherapy, now getting up past 13 when we saw the IMforte results. But this is a game changer in that respect, because now we're seeing in excess of 2 years. And extensive stage small cell is something where you don't tend to see a lot of outliers like this. Unlike in non-small cell, where you might have a favorable group, let's say, that have a lot of driver mutations or something, we don't tend to see any particular group of extensive stage small cell that has particularly favorable outcomes. And now you've got a pretty good-sized study showing a survival in excess of 2 years. And that's from the time of maintenance therapy. That's not from the time beginning. So even though right now tarlatamab is approved in the second-line setting in the US, when we look at the strength of these results, it's hard for me to imagine that this won't become part of the first-line regimen at some point in the near future. So excited to see the results with lurbinectidine. I think a very solid step forward that should become a standard regimen in the United States and is now FDA approved. But I think with tarlatamab, we're seeing something that may be more of a game changer assuming the results hold up when we get to randomized studies, and there's no reason I can think of that they wouldn't hold up. I didn't see any factor with patient selection or anything that would make me think this was an atypical group.
Dr. Peters, can you tell us about recent advances in non-small cell lung cancer?
Today, we have been developing this pie of non-small cell lung cancer and speaking and focusing first on advanced disease, making us understand that in Caucasian patients in our environment, probably a third, up to half of the patients might benefit to something else than the classical chemoimmunotherapy. And this subdivides this 30 to 50% of the patient into very small subgroups where at the end, we start to develop precision oncology and targeted therapy in almost all of the circumstances. We had some missing players or not really satisfactory treatment options. Remember KRAS, which was called for a long time undruggable, and HER2, which was not druggable by nature of the mutation and by nature of the compounds we had. And today, we have an abundance of HER2, I would say, targeted therapies, and even more on KRAS off blockers that come and meet the paradigm of best treatment first, meaning that they escalate the lines of treatment to go frontline. So I think all of these now low-hanging fruits, these oncogenes that our NGS small panels identify better, remember if you have an RNA component for the rearrangement, all of these mutations have now targeted therapies which should be given frontline. We are even revisiting this targeted therapy in the adjuvant setting, like it was done for ALK and for EGFR. So I think really changing and dividing the world of non-small cell lung cancer into this oncogene addiction with actionable genomic alterations and the non-oncogene addicted, which again has also seen lots of advances with the confirmation of the efficacy of immunotherapy, dual or mono checkpoint inhibition. So I think we have been, and it's nicely seen, by the way, in a recent review from the French environment, we have been seeing massive improvement in survival of these patients. If you look at the whole population of a country, decade by decade during the last 30 years. And this really proves and showcases how much we have advanced in all circumstances of non-small cell lung cancer. There's another abstract which was presented at the World Lung, which is absolutely, I would say, changing the landscape, even if we suspected it would happen. This is the FLAURA2 overall survival abstract. Remember that in the field, and we are here, non-small cell lung cancer in patients suffering from classically mutated EGFR, non-small cell lung cancer, exon 19 deletion, exon 21 L858R. These patients usually received osimertinib frontline. This had been compared to first-generation TKI. Osimertinib is a standard of care, better PFS, better overall survival. But since some 6 months or a year, we challenge this by trying to escalate this osimertinib or by adding chemotherapy on the top, which is FLAURA2, chemo-osimertinib, or by switching to lazertinib amivantamab. It's interesting, it's a real competition between the two escalation processes, but the elephant in the room is why and for which patient you need to escalate. So basically, this is a very important and awaited data set because we knew already from previous presentations that the amivantamab lazertinib was improving survival, but with the median not being reached and just projected, but with a significant hazard ratio at the final analysis for survival. Here we, for the first time, see the survival data of osimertinib chemo versus osimertinib in this more than 500 patients population randomized. In that trial, remember that the PFS was showing a hazard ratio of 0.62 in favor of the combination. And in the presentation of the World Lung, we could see a quite amazing hazard ratio for survival of 0.77 being statistically significant and making a difference, which we should not neglect in our field of research, of 10 months. So 10 months gain in terms of survival by adding the chemo. So here the main question comes to me. Later on at the ESMO meeting, for example, we could see that this hazard ratio is found across all subgroups you can imagine. Type of mutation, brain mets, P53, ctDNA measurable at baseline. The same magnitude of benefit as translated by hazard ratio is seen across subgroups. So the main question is, Are they very good prognosis patients for whom you cannot escalate? I'm still not convinced myself, because it will be the first time in my career that we decide to ignore a benefit in overall survival of 10 months. I mean, for most of the things we've been doing, we would have found it absolutely amazing. So I think we need at least to discuss this FLAURA2 escalation in all patients. And of course, like usually, some patients will reject the chemotherapy. And that will be fine, and we give the osimertinib. But I think this educated discussion has to happen with every patient. And last but not least, I think that chemotherapy and osimertinib is still better tolerated than the amivantamab toxicities, which is a class effect of EGFR with a rash, paronychia, and GI toxicity, which makes probably this combination slightly easier to use. So I think this overall survival data confirm that probably we have defined a new standard of care, which might not please all patients, but which might and have to be proposed to all patients. There are also two abstracts which go into the niche of oncogene-addicted, very small subgroup of patients. First one, let's go and look at the HER2 mutant. So Beamion LUNG-1. John, you were involved and treating patients. So what are your thoughts about the benefit you can expect from such a strategy?
Well, we've had a lot of new exciting findings in the HER2 mutant non-small cell lung cancer space. I can briefly review those having to do with zigertinib. Just to remind everybody, HER2 activating mutations are roughly 2 to 3% of non-small cell lung cancer cases. These are not amplification or overexpression. HER2 overexpression is something that can potentially be treated with trastuzumab deruxtecan. These are activating mutations, and the vast majority of these are exon 20 insertions. In fact, 70% of them tend to be one particular HER2 exon 20 insertion. It's what we call the YVMA insertion that happens at the 772 location. But anyway, so that's the population we're talking about for HER2 mutant non-small cell lung cancer. Earlier drugs that were tested in this space, and we had done a lot of work with poziotinib, for example, had the challenge that while they may inhibit tumors with HER2 mutations, they had a lot of EGFR-related side effects, rash, diarrhea, and so forth.
We tried, many trials also, to put TKI in that setting with very low level of response and kind of huge toxicities. There's a whole list of drugs which didn't pass, I would say, the bar of significance.
So zigertinib is really the first drug we've got in the clinic that is able to inhibit HER2 mutant tumors, but is wild-type EGFR sparing. So it avoids the toxicities that go along with inhibiting the wild-type EGFR. This, in August of this year, received FDA approval for previously treated patients, and that was based on an objective response rate of 71%, median progression-free survival of 12.4 months. But what was not described in detail in that initial New England Journal manuscript was the activity in brain metastasis. So at the World Lung Meeting, Dr. Ruth and our team presented the results of patients with brain metastasis. And there were really two cohorts that were involved here. Cohort 1 was the cohort involved in the FDA approval. Those were previously treated patients but who had never had a HER2 inhibitor before, but they had received prior platinum or immunotherapy. And in particular, this was the presentation of the patients who had brain metastasis at baseline from cohort 1. And then the second group was cohort 4. And cohort 4 consisted of patients who had brain metastasis that was measurable by RANO-BM criteria that we like to use for assessing brain metastasis. So to summarize a lot of this data, the overall pooled analysis, the objective response rate from 58 patients with brain metastasis was 41%. And if you looked at the cohort that had not received prior brain radiotherapy, the objective response rate was 44%. Disease control rate was 83%. So I think at the end of the day here, this shows that zigertinib clearly has CNS activity. Now, the response rate is moderate. A response rate of 41% is a little bit lower than the response rate systemically, but it's still clear evidence of CNS activity.
So really showing that this is a compound which can be used like osimertinib for EGFR in patients with asymptomatic brain mets, and probably allows us to push to a later time point the opportunity of giving radiation. At least that's what we prefer to do in asymptomatic patients. But there was a continuation of the story.
At the ESMO meeting, Dr. Popat and rest of our team presented the first-line data for patients who were previously untreated with zongertinib. And here the activity was really outstanding. Objective response rate was 77%. The median PFS hadn't been reached at the time of that presentation, but it appeared to be well in excess of the 12 months that had been seen in the second-line setting. And the safety and tolerability showed that it had a very manageable safety profile, as had been seen in the second-line setting, with low rates of grade 3-4 AEs, low rates of significant diarrhea, and virtually no rash of significance seen there as well. So the bottom line from all that is zongertinib has substantial activity in the first-line setting for patients who have not been previously treated, and it's got clear evidence of CNS activity with a response in the brain of 41% from the pooled analysis of the cohort 4 and cohort 1 patients.
In the same sort and line of thinking and perspective, we had another niche, which is the ROS-positive non-small cell lung cancer. Again, something like 2-3% of our non-small cell lung cancer population, which now is targeted by many compounds, talretrectinib, repotrectinib. We have many ROS1 inhibitors, but probably recently, talretrectinib was showing the highest, I would say, efficacy and has a competitor. The competitor is zidesamtinib, the NVL-665, it's sometimes easier to pronounce, which was presented with a lot of data by Alex Drillion at the World Lung Conference. To make a long story short, Alex was able to present 3 cohorts of patients. One cohort was this patient having received more than one prior ROS1 TKI, from 1 to 4, very often new generation ROS1 TKI, meaning resistance mechanism which are difficult to address. A second cohort with only one prior ROS1 TKI, crizotinib or entrectinib, so not the most powerful one like talretrectinib, for example. And a third cohort, TKI naive, so frontline, a bit like we discussed before. All of these patients could have received chemotherapy, at least for the cohort 1 and 2 I described, and this is not a problem. But basically, if you are naive from any treatment, the response rate to this zidesamtinib is 89%. So the duration of response at 12 months is 96%. And again, to discuss precision oncology and new TKIs, the intracranial response rate, as centrally reviewed, was 83%. This is naive patients. So let's go to only one line of TKI. Response rate 51%. At 1 year, the duration of response is 93%, and still the intracranial response is 85%. Let's go later on in the patient having received 1, 2, 3, or 4 prior line of TKI, meaning some new generation. Response rate is still 44%, 78% still in response at 1 year, and the intracranial response rate, again matching the systemic response, is 48%. So conclusion, this is a very active drug in the resistant setting, whichever line of treatment you are in, but more importantly, and again, like discussed before for the zongertinib, right, giving it frontline develops the whole paradigm of the best efficacy, and remember, confirms the idea we always have of the best treatment first. So let's try to always position the best treatment frontline.
Thank you, Dr. Heymach and Dr. Peters, and many thanks to you, our listeners, for joining us. As a reminder, to view the full program, CCO Independent Highlights at the 2025 World Conference on Lung Cancer, please click the link in the show notes. And be sure to check back regularly for more episodes on important oncology topics.